Hi, everybody, and welcome to the Mind on Mental Health podcast. My name is Andy Dean, and I'm a licensed clinical social worker. Today, I'm once again speaking with Dr. Susan Murray, supervising psychologist at Penn Medicine Princeton Center for Eating Disorders. On this podcast, Dr. Murray and I discuss the treatment philosophy that we utilize at our PHP-IOP and what she considered when training our therapists to work with this population. I hope you enjoy the episode and find it helpful. So we just talked about ACT a little bit, and experiential avoidance is one of the concepts in ACT. What else? Are there other modalities, I guess, is a question I want to ask that we're kind of pulling from, or that you pulled from. And can you give me maybe examples from those contexts as well?
Yeah, so we have one that's called CBTE. Most people might not be familiar with this because it is CBT that's specifically designed for eating disorders.
Okay.
It stands for CBT Enhanced. And so that is very obviously already tailored towards eating disorders. So we didn't have to do a lot of legwork there, which is nice. But it helps to walk someone through not what led to the disorder, right? But what keeps it going on the day-to-day? What are the maintaining factors?
So like what might lead to the behaviors that keep it
going. And then trying to understand each person's sort of maintaining factors and taking each one of them and working to not engage in those behaviors. So that could be, for example, like weight checking, right?
Yes.
So the more someone is checking their weight, the more they are kind of preoccupied with that number changing and have more anxiety, which then leads to more engagement in eating disorder behaviors as a way to modify that number or maintain it. And so one of the things that we really focus on is not engaging in weight checking behavior. So our team is responsible for checking the weight. We ask that people trust us, which is a big ask.
I could imagine.
That we will monitor their weight. And for some time, blind weighing can be a really helpful intervention to reduce preoccupation with that number. And then over time, we want to move towards exposures to the number so that no one is really thrown off. They get to see that number as just like a hopefully a little bit more neutral metric, similar to blood pressure or something like this.
Interesting. So the question that I want to ask, the follow-up question to that is how do you know when a person's ready to switch from you guys keeping track of the number to them being ready to do exposure?
I think that there's probably never going to be a point where someone's like, I'm totally ready, let's do it. But you can get a sense that someone, has been able to change a lot of other behaviors. They're in a little bit of a calmer headspace around this number. They've been able to kind of relinquish the control to the team for some time. And then really what I want them to be prepared for is the fact that they could encounter that number just in the day-to-day. They're at a doctor's office, right? Whatever. So that's when we would kind of bring it in and say, we're going to share this number with you. We're going to, have kind of a moment to process it together. And it is okay for them to have a difficult reaction. That's normal. That's to be expected. It would be very strange if they didn't have a reaction, if they were, that it has held such salience for them for so long. So I think we don't want to sort of wait until they're so far out of the woods with this illness that we introduce it. So we have to anticipate that there's going to be some affect around it. That's normal. And
Okay. Yeah, I would imagine it's pretty individualized as well.
Yeah. It's difficult to say at this point,
of course,
create rules
3 days
around that.
Okay, that makes sense. Is there anything else you might want to say about
the program?
How we're designing the program to make it innovative or different?
Yeah, so one thing that's been really important to me is that, many treatment centers will plate patients. They will provide the food, they will augment their meal plan, right? And someone can sit down and eat. Maybe through time they're eating more and more. They're able to complete their meal plan. they make nutritional progress, they make weight progress, maybe they're even trying some like unsafe foods, right? They're like challenging their fears, wonderful, beautiful. And if they discharge and they do not have experience making in the moment decisions around food, I really believe that we have done someone a disservice in preparing them for the real world, because that's where it's happening.
Yes.
Right?
So what does that look like?
Yeah.
Yeah.
So first and foremost, we want people to have the experience of choosing to start out with their snacks. So they kind of have like a lot of different cabinets with a lot of different options, and they have like a short amount of time to choose the snacks that they're going to have for the day. It's not a ton of cost-benefit analysis, not a lot of time to get into that paralysis that can come with decision making when you struggle with anxiety. So getting used to making choices, and then starting to portion in the moment. So we have a family meal every Friday for lunch, where we have like really much larger portions instead of things being plated, so that people can practice. And all of this is done with the support of therapists and dietitians who can provide feedback and guidance. Then we have folks bringing food in from home as they go, so that we can see what are the kinds of choices that they make. They're getting the opportunity to go to the grocery store, make choices when they're preparing the meals, bringing them in. We're kind of talking through all of that. So having that decision making be built into the process of treatment, I think, is really, really important, and will provide a sturdier foundation for recovery.
I think that makes sense. So like at other programs, it might sort of get like prepackaged meals, and it's just like, here you go, we're going to eat this. But that doesn't really account for what's going to happen in the real world.
Right, like it's one thing to eat something that's provided to you. It's another thing to be the one who's making the decision around what you're going to eat.
And all the anxiety and rumination that could come along with having to make that decision.
Exactly, yeah. So we wanted to build that into the program itself, so that people feel like, okay, I'm ready to really make recovery-minded decisions on my own.
Makes sense. We talked a little bit about the different modalities, like we talked about ACT and CBT, and maybe that was all we got to.
We have DBT, RODBT.
Yeah, right.
IFS is another one that we've been doing, yeah.
Okay. And I guess what I'm curious about is like, you've been in charge of training the therapists that are working on this new program, the PHP-IOP. I'm curious about both, I guess, the modalities, but then also like in your mind, when you were trying to decide how to set these therapists up to do really good work with the patients, what was sort of like the checklist that you have going on? Like, if someone comes to me for, let's say, OCD or panic treatment, I kind of know what I want to make sure that, what psychoeducation I want to give them, and like how I want to go about this process. And it's not necessarily even a specific modality. It's just kind of like the psychoeducation or the philosophy that I want to like instill in them. Yeah. So I guess I was kind of more curious about that angle instead of any specific modality. Does that make sense?
Totally. Yeah. Okay. Yeah, I did want to provide a lot of psychoed to our therapists around what the experience of an eating disorder is like. I think there's a ton of information people can get about statistics or whatever, but it's different than thinking about like what are our patients actively thinking about and feeling on the day-to-day, what's driving their decision making. So that was really important for me to give them insight into the experience of the illness. It's also a way to have a ton of compassion for what our population is struggling with.
Can I interrupt you for a second?
Yeah.
I was just thinking that like one of my favorite moments sometimes in the therapy room is when the patients get the impression that like I'm reading their mind, because I say like, I could imagine that anxiety might be saying this right now. Or when you're in this situation, they're like, oh my God, how did you know? Like, how did you know that? And I guess that's sort of the vibe I was getting from you when you were talking about why you really want them to understand what their experience might be like.
Exactly, so that they can convey to patients, first of all, they can understand and sort of anticipate where things might be going, right? But so that they can convey to patients like a deep understanding of the experience.
Right.
Because I think, you know, I had a patient yesterday tell me, "Are you in my head?" You know, like how? How did you go there? How did you know?
Right.
And it's just because I've been treating this illness for quite some time, right? But I think that was an important part of my training for the therapist. And then also a lot of training around the neurobiological side of things.
Thanks, everyone, for tuning into the podcast. Join us next time as I talk to Dr. Murray about the neurobiology of eating disorder treatment and why that insight is so important. See you next time.